your patient has dry eye syndrome. Obviously, they're coming to you with their third or fourth opinion, or that's their main complaint. I have dry eyes. I've been using Refresh, Sustain, Blink, all those artificial tears. Obviously, they're not working. What is your first line of therapy? Like, what's the first one that comes to mind?
Yes, the way that I do things is...
Are you ready? Hi, guys. My name is Andreas, and this podcast, we have dry eye specialist, one of my good friends, Dr. Julian Prosia, here with us today. Good to have you here today, buddy.
Nice to be here, buddy. Thank you for having me on.
Of course, of course. I've been wanting to set this podcast up for a while. We have a lot to talk about in terms of dry eye and treatments that every optometrist should be doing if they want the best outcome for their patients. And I know you're the right person to talk to because that's your specialty. So I'm really pumped about it. I'm pumped to learn from you. So let's get into it.
Love it. Absolutely.
First off, before we get to specifics, just tell me a little bit about where you're working and how long you've been there.
So out of school, I worked in South Florida for about 2 years. That's where I picked up the majority of my dry eye knowledge and experience. And me and my wife recently just decided to move back to my hometown in Canada. So I just started a new position with a great company, great private practice. They're called Mountain Eye Care in Hamilton. So just getting off to starting with them and looking forward to the future with them.
Heck yeah, man. Big moves. Really excited for you. How is it, though, that you got into dry eye specifically?
Yeah, so getting into my last year of optometry, I was more kind of inclined to do what I think a lot of people are doing, contact lenses, ocular disease, things like that, which are phenomenal. Definitely we need more people to do that type of stuff. But as I started to get into my rotations, I noticed that there was a lot of people suffering from dry eye issues, and there wasn't a lot of people who actually treated those problems, like specialized in those issues. So when it wasn't until I got into practice where I started to see, 30 patients a day and notice that majority of the complaints coming into the office were dry eye related, and that they've been to like 5, 6, 7, 8 different places. And, these doctors are just giving, artificial tears, the basic stuff that you're taught in school. So at that time I decided, I'm going to go a little bit different. I'm going to create my own niche. And so I took it upon myself to read through articles, learn on my own, go to these dry eye summits, and then it just happened like that.
No, good, man. It's definitely paying off. I mean, I see you on Instagram putting all those, all that dry eye content. I'm always happy when I see it. By the way, follow Dr. Julian Prosia at Dr. Prosia.
You could put it right up here if you want even.
Yeah, I got it. I'll edit that too. Cool, man. So now on to dry eyes. I want to start off, you just mentioned this just a second ago, but I want to start off by talking about artificial tears because I know how you feel about this.
Yeah.
But do you ever treat a patient with artificial tears only, even if it's like very mild dry eye or just like really symptomatic, or just like a routine exam? What are your thoughts?
Yeah. So, I feel like, going into, learning in school, I talk to a lot of people and they ask, what are we learning this for? The majority of the reason why we're taught this stuff is because we're preparing ourselves for boards, which is not a wrong thing. A lot of the knowledge that you learn in school is really important. It's going to be the basis, of knowledge for you for the rest of your life. But when you get into practice, you'll notice that it's not just 1 + 1 = 2. You're going to notice that 1 + 1 = 100. There's people that come in and you give them the proper treatment that they're supposed to get. Artificial tears, warm compresses, lid scrubs, what you're taught in school, and they will come back and you will fail every single time. And that's one thing that I tell anyone who asks me, people that reach out, hey, I really want to get into dry eye, what should I prepare myself for, or what do I need to do? You have to prepare yourself to fail, and you can't be afraid of it. Failure is how you grow as a person. It's how you grow in your career. And dry eye is one of those things. It's a chronic issue. You're going to fail more than you actually, see success up until you figure out something that really, really works. You create your own kind of, or what I like to call like menu for dry eye or concoction, right? So do I use artificial tears for, my very, very mild patients? I'll tell you that my very, very mild patients who are very young, like I do have a lot of kids that are, juvenile rheumatoid arthritis,
Hmm.
referred for rheumatology, and, they may be at an age where I don't, necessarily want to put them on a steroid at this moment. Very, very mild, focusing problems. Yeah, sure. But majority of my patients, I go by this menu that I've created. I call it from level 1 to level 5. And, you
Hmm.
know, it is in a way cookie cutter for, the basis of how I treat dry eye, but it's customized to that person based on, what they do for a living, based on what the eye looks like, because every single person is variable, every single person is different. So in the long term, to answer this question, I would say I don't always just use artificial tears. I'd say 90% of the time it's mixed together, rather than just using artificial tears as a single therapy.
Okay.
One thing that people also have to understand is that dry eye is defined as a multifactorial disease, meaning that if we just approach it from one angle, you're not going to get the success that you want. And so that's why another reason why I don't just use artificial tears. And we'll kind of
Okay.
go into it more.
Yeah. No, I gotcha. And it makes sense for you too, because I feel like, you know, my clinic schedule, it's like patient comes in for a routine exam because I work at a cataract LASIK center. So like we do a
Right.
lot of dry eye, but a lot of times that's not why they're there. So it's like if they're there for their cataracts, but then also have sometimes my eyes are dry, I might say, okay, here's some Cystane, and if it doesn't get better, call us back, or I'll see you in 2 months or something like that. But then if like they come in specifically because hey, my eyes are dry, fix this, then it's like all right, well, tears ain't gonna cut it, even because they're probably using it 4 times a day and at that point, you want something a little bit stronger.
Exactly. I know. I was just going to say it really depends on your practice modality. Like, there's no optometrist or ophthalmologist that works in a practice and does the exact same thing every single day. You're
Hmm.
working in a cataract LASIK center. For me, it's like a lot of my patients are coming from referral systems. I've been able to build, referral systems through multiple
Hmm.
rheumatological practices. A lot of rheumatologists are referring to me, other ODs. So a lot of my patients that are coming to me are already like, I want to say like third, fourth opinion, a severe,
Mm,
severe dry eye problem. So it's for someone that's just starting out in a private practice like yourself, who's working at like a specific specialty center, it wouldn't be a bad idea to just, give them, hey, listen, protect your eyes. It's good to use just lubricant, morning and night. Get started on that. If there's a problem, let me know. Like something like
mhm.
that, right?
Yeah, yeah. Which goes to the next question. So your patient has dry eye syndrome. Um, Obviously, they're coming to you, their third or fourth opinion, or that's their main complaint. I have dry eyes. I've been using Refresh, Cystane, Blink, all those artificial tears. Obviously, they're not working. What is your first line of therapy? Like, what's the first one that comes to mind? Do you do plugs or do you do steroids or something else?
Right. So once again, it's very dry eye is not cookie cutter. So
Hmm.
first
Okay.
thing I do is I assess them. We always do an OSDI. For anyone that doesn't know, that's a questionnaire. We want to quantify dry eye, because when you look at dry eye, it's a quality issue. It's hard to quantify. You can't say 2020 versus 2040, right? So we want
Mm,
to quantify the amount of dry eye that this person has and how they feel it. So that OSDI is phenomenal. We can quantify it to a number, right? When they
okay.
come in, we do our basic setup. We do the fluorescein staining, taking a look at the front surface of the eye. I love the mybomography as well, as fantastic. Anything that can get us to kind of see some of the structures that may be involved in, creating these problems for this patient.
Hmm.
And every different practice will have their own setup. That's what I do in my practice, right? So looking at the front surface of the eye, if they've been using tears, they can't, get to that point, or what I call their threshold of relief. I usually say, hey, listen, let's start from scratch. All right. I want you to understand the realistic nature of this disease. It's a chronic disease. You will not get perfection. You will not get cure, right? We have to remove that out of your brain, and we have to focus on managing or improving. That's that. I have to set the tone. Otherwise,
Uh,
the
yeah.
patients who think that they're going to get perfection most likely are going to fail. There's a stat out there that says that patients who start Restasis and are not explained Restasis will actually, over 80% of them will stop the therapy. When they
Mm,
restart the therapy and are explained it, almost 60% of those people that restart will actually have success, right?
No,
That's out there. That's an actual stat,
yeah.
right? So I take that time to explain to them the extra, couple of minutes. I explain the realistic nature of this. Now, if it's a very mild dry eye issue, I like to tell them combo therapies. It's a multifactorial problem. So I usually start with artificial tears 2 to 4 times a day. You don't want to overload your patient on artificial tears because artificial tears can, when you overuse them, can wash out the natural tear film. The same way you're not supposed to shampoo your hair 5 times a week to strip the oils. You can actually strip some of the oils out of the natural tear film. So I say 2 to 4 times a day, no more than 4 times a day. I get them started on a steroid. My choice usually is Pred, and we'll go into that.
Yeah.
I do that for about a week, 4 times a day. And what that does is reduces the inflammatory aspect of the issue. Dry eye is a multifactorial disease defined by inflammation, right? It's an inflammatory process. If I could change it from dry eye to inflamed eye, I would coin that term. But getting that steroid is very important. Now, adding other supplement, very important. Cleaning the lids with an OxySoft lid scrub. I start simple. Artificial tears, steroids, OxySoft lid scrub, come back in about 2 weeks, okay?
2 weeks.
At that point, if I see that their T-bud is low and that there's a low tear film, I opt for the collagen dissolvable punctal plugs, right? To boost up the amount of tears you can hold in your own eye. Remember, the biggest thing that I say to my patients, artificial tears are great, but they don't actually have the enzymes, they don't have the antibacterial properties, they don't have the nutrients that our natural tears do, right? If you add too many artificial tears, you can strip off the natural tear film. You have your natural tears, you're rebuilding yourself, right? Okay. So that's the way I get my patients started. Warm compresses, not a big fan. I'll tell you why. Warm compresses, look at the physiology behind what a warm compress does. A warm compress dilates the vessels and allows your immune system to come to that site. That's why we use it for infection. For an inflammatory disease, whether it be blepharitis, whether it be meibomian gland dysfunction, whether it be dry eye as a whole, why would you want to bring the immune system to that site to improve the amount of inflammation in that area? Right? It just doesn't make sense. And there's a really, really well-known dry eye specialist. She's an ophthalmologist. She always talks at these dry eye summits. I can't remember her name. I have to get it for you so we could put it on here. But she says in a quote, supplements like OxySoft, artificial tears, because artificial tears are not a treatment, they're a supplement.
Right.
And warm compress can be used to help or supplement dry eye treatment, but they do not address the ocular inflammatory problem. And that is what makes up dry eye. So that's why, yes, removing bacteria with the lid scrubs, yes, supplementing the tear film with an artificial tear that may wash out some extra allergens or things that will, cause that inflammatory response to start. But warm compress, for me, my patients don't see a difference. Physiologically, it doesn't make that much sense to be using it consistently. And, it's not addressing the root cause of the problem. So that's how I get my patients started. For anyone that's looking to start treating dry eye, your key factors that you take from this question away is that, number one, you are explaining things to the patient. Take the extra couple of minutes to really look hard at the lid margin, the meibomian glands, the front surface of the eye, and stain the tear film, right? All the surrounding ocular structures are very, very important to help kind of push this patient into success, right?
Yeah, no, that is awesome. I love the first thing that the main thing you stress is set expectations, because, a good way to compare this to is multifocal contacts. Like, how many times you have a patient that expects they're going to see 20/20 distance and near, and then if you only take that extra, I know you're behind in clinic, but if you take that extra 2 minutes, they're going to come back, they're going to be unhappy. But if you tell them, hey, like, it's not going to be perfect, it's a compromise, and we're not looking for 20/20/20/20, we're looking for 20 happy. As long as you can read the sign, look at your phone, farmers, medication period is going to be very small. So as long as you set all that up, that's then you have a much higher chance of success. And so I like how you go about that route. You mentioned the steroid 4 times a day for just a week, and then you just stop, right?
Yes.
Okay.
There's a lot of research behind that showing, I know a lot of people are very, very scared because we were taught in school, you know,
Yeah.
you're a steroid responder. Oh my gosh, right? Pred, I've been using for a while now. Do I have people that steroid respond? Yeah, but you're seeing them back in 2 weeks, right?
Yeah.
Mild dry eye, I use 4 times a day for a week. There's research behind it that you do not need to taper the medication for 4 times a day unless it's past a 2 week time period.
Week time period. Okay.
So, yes. So, you're doing it for 3, 4 weeks, taper it, 4, 3, 2, 1,
Yeah.
right? You're doing it
Okay.
for a week, you're doing it for even 2 weeks. I never taper that. Now, every
Okay.
doctor has their own opinion. I'm not saying that anyone is wrong, but that's how it works for me based on the research. It's the best steroid for dry eye. It actually penetrates deeper. I know
Yeah.
FlareX actually, I have to say, anyone that uses FlareX, it's great because it's got the strength of Pred, but it has, that low risk compared to, it's got the risk of lodiprednol. The only thing is, you know, patient may be paying a pretty penny for FlareX versus Pred.
Yeah.
Pred is,
It's pretty expensive. I know Flarex is fluoromethalone, so I feel like there are a few, I won't mention names, but there are a few pharmacies where you try to prescribe that and they'll tell you it doesn't exist anymore, which is like,
yeah,
of course
exactly.
it exists. You just don't want to pay for it. So,
Or yeah, ethanol acetate. Yeah, the patient actually isn't covered for that. They'll be covered for Durezol. It's like they're totally different things.
yeah, I know, not at all. But I really like that taper because how I personally been doing it and how I guess the other ODs in my practice have been doing it is they'll see a patient for dry eyes and then see them back in like a month or 6 weeks. Which that makes the taper tricky. It's like, okay, so it's like, okay, 4 times a day for 2 weeks and then once for 2. And so I feel like it's always like, okay, you got to make a taper schedule. And the patient, it's just more of a burden on the patient. So I really like the fact that if you just hit them hard for a week and then just stop and then see them next week, that way it's like if the Pred helps, because this is the other thing I get. I'll get like, oh, it helped at first, but then like not really. But if it's like 4 weeks after, and then on that fourth week they're only using Pred once a day, I wonder how quickly that effect diminishes. So
Exactly, and that's one thing. It's not even just about the fact that the way that I created my schedule in terms of how I see patients back is because at the beginning I was doing a month, I was doing 2 months, but then I started to realize, wait a second, steroids are a short-term. I always tell my patients it's a short-term help, right?
hmm
Why am I seeing them back in a month? Why am I seeing them back in 2 months? So 2 weeks is great because it improves your patient retention. It
hmm
allows the patient to stay on it, get in their groove. You ask a patient, "How were you a month ago?" They're going to be like, "Well, my son's birthday is the last thing I remember, and that was last week." So it's
yeah,
like if they come back in 2 weeks, they've been diligent with their stuff. You're kind of guiding them. It's like they're on training wheels. I'll do the 2 week, and then once I start to see that they're doing better, then I push them out for a month. Then I see
hmm
improvement. Then I push them out for 6 months. But the key for treating dry eye is you want to be, the parent basically helping the kid, ride a bike, right? Until they
hmm
can do it on their own and they can feel comfortable and they can go outside and they don't get the light sensitivity. It's super important. And I think that's a lot of the reason why people will get reduced retention. And you'll have these patients say, I've seen 5 doctors, 6 doctors. What have
yeah,
you done? Oh, they gave me artificial tears and warm compresses, said come back in 2 months. And then they're like, but I still feel like crap. You know,
yeah,
so it's a different way of looking at things. I know we weren't taught this in school, but it's definitely something that I think every doctor should really, really think hard
yeah.
about. We don't have to be the yearly see us in 6 months doctor, right? We can be, hey, see us in a week, see us in 2 weeks, see us in 4 weeks, et cetera, right?
Yeah, no, I really like that because I was thinking about this the other day. I had a patient when I first graduated where I saw her, okay, tears, see you in 4 weeks. Then, oh, steroids, see you in 4 weeks. Kind of better, but not really. Okay, now we're doing plugs, see you in 4 weeks. And then I lost her. And then at first I was like, what the heck? Why should I come back? And I'm like, dude, she's been seeing me for like 4 months. So obviously at some point she's like, I'm done. I want to see somebody else. Or it's like, oh, I'm not fixable. And so, because to them, like, it's easier for us to say, okay, it's 4 weeks. It's a scheduled plan, and I'm going to see the next patient, and then, like, they're going to come soon. But for them, it's like forever. So they're dealing with it for like a really long time. So I really
Yeah.
like the idea of, like, hit it hard with steroids, very short term, see you back in 2 weeks. and then assess. Like if it's gotten better in 2 weeks, do you still go to the next treatment, or do you say, okay, like see you back in a month or something like that?
What do you mean that if it's getting worse, you said?
Oh, sorry. I meant if so you use Pred QID 1 week, see him back in 2 weeks, and now they're like, oh, I'm better. Do you still kind of do something else to kind of make it more chronic?
100%. Because the biggest thing I stress is that you will see improvement. I expect you to see like a step of improvement. Yeah. But this is short term. This is short lived. The steroid's doing great, but how are we going to keep it like that? And so that's when I start to say, let's go into the punctal plug therapy. Now, this is not for every patient. This is for, a patient who, like we talked about, struggling with dry eye, low T-bud, some inflammation, been struggling for a while. I get them into the plugs because now we've reduced that inflammation. The biggest analogy I use is you have a muddy pool. If you're just adding tears or water into the pool and it's muddy, you're just going to make a very muddy mess of the pool. Now, if you clean up that mud, which is what the steroid does, now you can relubricate. Now you can add your natural tear system to go in there. And so that's what the plugs do. It builds up a nice, healthy pool of tears. So now when the patient comes back, usually if they're doing well after 2 weeks, I'll say, I'll see you in 4 weeks now. We'll push it out to a month. They usually come back and say, Dr. Prosia, I actually feel fantastic. Sometimes I have them come back 2 weeks after they get the plugs and say, how are you doing? Checking in with you. I'm feeling great. Maybe I have a bad day here. Maybe I have a good day here. I do have some patients that will come back and say, hey, I feel better, but I'm not perfect. And then that, once again, you're stressing the realistic nature of the disease. I always tell the patient, whoever's telling you that you're going to be perfect or you're going to be better, that's false. We're going to take one step at a time. In a month, if you have 4 bad days out of the week and you used to have 7, that is fantastic. Right? It's a win. We got you 3 more good days out of the week. And then 4 or 5 months later, you come back. Wow. You got 2 bad days out of the week. It's really just you're hand holding them until they can be on their own. Yeah. It's very important to stress that.
No, that's awesome. I really love that mentality. Okay. Yeah. So steroid, and then next step is probably plugs. You did mention collagen. Do you do like the 1 to 2 week collagen, and then if it works out, then do the extended duration collagen?
Yes, the way that I do things is a little avant-garde. I use a 2-week dissolvable plug as a trial plug. I trial the patient so that they feel comfortable having plugs in their eyes. Some people don't. I would say less than 2%. 98 to 99% love the plugs. So I put the 2 weeks in, they dissolve away. They come back in 2 weeks. Once again, it's just to kind of handhold them and say, hey, are we making some progress? So we'll do the 2 week, let's say, follow-up after steroids. If they've used steroids in the past and artificial tears, I jump right to the plugs on that day. If they are brand new, they've never used any steroids, they just use the tears, I'll do the 2 week, after steroids. Then I see them back. We do a trial set of plugs the last 2 weeks. I see them back in 2 weeks after that. And then finally, when I do that, I'll do the 6-month plugs. And then that, either I push them out for a month if I know that they're pretty severe, or if they're doing super well and they're like, doctor, I feel fantastic. Like, I haven't felt like this ever. And they're a mild dry eye, I'll give them 6 months. And I always say, give me a call. I'll get you in that day. Just let me know. Check in with me, right? It doesn't have to be that your appointment's at 6 months. Don't talk to me for 6 months. No, check in with me, right?
Okay.
So depending on the severity, depending on what they've had in the previous, I'll either, starting from scratch, someone's never done anything, artificial tears, steroids, education, come back in 2 weeks, start a plug therapy for 2 weeks, the trial sets, come back 2 weeks after that. And then that's when I make my decision, okay, a month, 6 months, et cetera, et cetera.
Yeah. No, that's great. I love it. I love it.
Awesome.
Use collagen. Do you ever, I know in the past you didn't use, I don't know if you do now. Do you ever use the silicone plugs?
I am against silicone. And I don't want to take shots at anyone for that uses silicone. You're not necessarily doing anything wrong, but as a doctor who practices evidence-based medicine, silicone has its problems. Okay. Number one, you have a chronic problem. To say that you're doing a permanent solution for a chronic problem is a wrong thing. You can't do it. They're not permanent. It's not going to permanently fix the problem. Number two, the amount of bacteria and the amount of inflammation that gets trapped on the silicone, right? That silicone it just grabs that bacteria. I've pulled silicone plugs out of patients. They're just covered in mucus. Oh, they've been there for 6-7 months, right?
Yeah.
The idea of silicone plugs is that you're blocking the tear film, right, from draining out. The problem lies with this. There's a high percentage of silicone plugs that get lodged inside the lacrimal canal. That can cause infection. Right?
Yeah.
We've had patients where we've had to cut out silicone plugs that have been stuck and infected inside, the duct, right? It's very possible that this stuff happens. So I wanted to remove myself out of that. The second reason, the physiology behind it. Silicone plugs block 100% of the flow. Tell me one pool that someone has in their backyard that does not have a filter. You need some of the inflammation to drain out. And I know a lot of people say, you have the punctum, above. Yes, but 80% of the flow goes through the bottom punctum because of gravity, right? So if you're blocking 80% of the flow, are you really, allowing that bacteria or inflammation to filter out?
Escape.
Not really, right? Collagen, number one, is healthier because it's part of our natural body. They dissolve away, and it forces the patient to come back for their follow-ups instead of having the permanent solution. There's a lot of misconception. I'm doing something permanent for a chronic problem. Patients going to think, oh, well, didn't you do that? Didn't it fix it already? Well, no.
Yeah.
Right. So that's a big thing. With collagen, it allows the excess or any of the muddy water to drain out. It dissolves on its own. And the fact that we know it's not going to cause infection, right? They're more comfortable. So there's just so many more wins. I think that silicone, people, like I said, are not wrong for using it, but I like to mitigate my risk. And I also like this evidence-based medicine, and based on the evidence, collagen is much, much better for the patient.
Yeah. No, I like your response, and I know, I feel like collagen versus silicone has been like a hot topic for a while. Right. Actually, recall there's an article in Review Optometry that came out, I think, like 2018 by Dr. Cequa. And first off, he quoted this Dr. David Sackett, and I love this quote because it says, "Half of what you learned in medical school will be shown to be either dead wrong or out of date within 5 years of your graduation." The trouble is nobody can tell you which half. so this kind of going to what we're talking about with how school and clinic is always changing. I think the article was saying how a few years back, like maybe 5+ years ago, silicone was just deemed like not good at all. Now the studies that are coming back are kind of like mixed responses. The one benefit I would say to silicone would be, and I think that's why a lot of doctors use it, a few providers in my practice as well, it's because I guess the thought process, instead of using collagen plugs every 6 months, it's like, okay, well, a silicone one just kind of solves that problem. But then I've had the same issues with you. Like I have a patient and they're like having irritation, and you see that silicone that's like 2 years old that's there. So I suppose silicone would be used better if it was like a take out after a year or something like that. But I guess just to be more consistent with your treatment, collagen is better. And I do love the filter analogy that you're using, because some tears do go through the collagen plugs, even though the collagen plugs are there, right?
Right. Well, the difference between a punctal plug that is silicone and a collagen plug, not a lot of people know this, is that the collagen plug is intracanalicular, meaning that it's in the canal. It's not in the punctum. It is going all the way into the canal, right? The punctal plug that is silicone is a true punctal plug because it's actually sitting on the punctum. Now, there are ones that they make, Oasis plugs I'm referring to. They make filters for the silicone. But think about what we tell our patients. Do not overuse your contacts. Do not put your contact on the cornea and leave it there for 30 days. Do not use a scleral lens or an RGP for over a year, replace it. Why are we not talking to our patients about silicone plugs that are in there for years? This is a film, the same reason with breast implants, right? Silicone, you use that for over 10 years, you can risk getting a chest infection, right? Or an infection in the cavity, right? It's the same thing. Silicone can become a breeding ground for bacteria. Why are we not changing it? Why is that not something that we are educating our patients about. So I just, I want more research to be done in that aspect. Dry eye is obviously me and and I'm not sure if anyone else knows this, but dry eye is relatively new. I mean, it wasn't until like 10 years ago that people really started honing in on it, right? So there's a lot of things that in our generation and the generation to come for doctors, we're going to see a lot of advancements, which is super, super exciting. But that's something, hey, listen, if you're a researcher and you're seeing this video, do a study on collagen plugs versus silicone, and then reach out to me and Dr. Andreas, please. Okay?
There you go. There you go. Awesome. I love it. Which brings, talking about the research, which brings to our next question, because, like I said, dry eye is relatively new, but we're already seeing so many new treatments out on the market. I'm going to ask you about that. So what are your thoughts on Restasis versus Xiidra versus Cequa? Because I know it's a hot topic as well.
Yeah. So first and foremost, the medications are phenomenal, right? I love the medications. I love what they do. But I hate the insurance behind it.
Dude, I know.
I hate the insurance behind it. You have these drugs, these eye drops that are more than some people's, car payments, right? Monthly. I've had patients say they're like $1,000 a month. I do have the odd patient. It almost seems like insurance is covering the people who don't need it, but like not covering the people who actually need it, right?
Yeah.
So it's very tough. It's very limited because of the fact that insurance doesn't cover it. In Canada, you can get it for cheaper. In the United States, it's a lot tougher. You have to have really good insurance, and you have to have a reason why you're using it, right? So the actual drug itself is phenomenal. You have the idea that you're reducing those T cells for at least Restasis and Cequa. You're reducing the T cells that are actually maybe causing the inflammation aspect of the dry eye problem. Do I use it for everyone? Absolutely not. There is a study out there that says over 40% of patients will not actually respond well to Restasis. Okay?
Really?
Yes.
Yeah.
Part of the reason why they think that is because of education and compliance. Part of the reason they may think that is because the patient, when using Restasis, isn't doing it properly. There's no other therapies that they're using. They might just be using it on their own. Okay. Xiidra is great too. A little bit of a different mechanism. I'm not going to go through the mechanism, but it is something that inhibits, once again, the amount of inflammation, and it helps you produce your own tears, which is valuable. I use them for my patients that have autoimmune related dry eye. The reason why I reserve it for patients with autoimmune related dry eye, obviously everyone knows the golden Sjogren's. Everyone knows Sjogren's, but you have to understand that any autoimmune disease such as Hashimoto's, psoriatic arthritis, ulcerative colitis, I'm not going to go through the whole thing, but any autoimmune disease upregulates inflammation in the body. Using a cyclosporin will help downregulate the inflammation in the eye and actually help it produce more tears. When you have inflammation going in the body, that can affect, the glands, that can affect your production of tears, all that stuff, or the quality of tears. So having these cyclosporins or these, types of medications are phenomenal. Personally, Andreas, how I use them is I use a steroid. Tell my patient, Restasis, Xiidra, Cequa, they are long acting. They take a little bit of time to start working. So what I do is I fill the gap with a steroid. So I'll do 4 times a day for 2 weeks, or sometimes up to a month, like a taper, 4, 3, 2, 1, up to a month, depending on the severity. And I also have them start Restasis, Xiidra, or Cequa at the same time. So I'm covering the short term and I'm covering the long term.
Okay.
Right. So that they get started right away. Their symptoms are improving right away. Right then and there, you've improved the patient's compliance and the chance of them staying on the drug. Because now they're thinking, I feel great. I don't know if it's Restasis. I don't know if it's a steroid. But I feel great.
You get it.
Right?
Yeah, because if you just use Restasis and you got to tell them it's going to take 3 to 6 months for it to start working, and it's tough. At some point, it's unbearable. So doing the steroid firsthand is definitely helpful. Does Xiidra take that long as well, 3 to 6 months?
It's very tough because a lot of the research is funded by the actual companies itself, Novartis and Allergan. So you know there is a little bit of skewing in there. Not to say that they skew the data, but I know that there's a lot of companies that they will do their own research, and sometimes it's a little biased, right?
Yeah.
I'd like to see over long-term meta-analysis reviews how long it actually takes to see improvement. I do know Xiidra, the physiology makes sense for it to start a little bit quicker than the T cells.
A little bit
T
quicker,
cells
yeah.
obviously it takes X amount of days for it to die off. They're inhibiting something else with the Xiidra, the LFA2, right? So it will work a little bit quicker, but I don't interchange them. I know some doctors will use Restasis and Xiidra. That I've listened to some dry eye podcasts where they do that. Maybe a thing in the future. I don't. I use Xiidra or Restasis or Cequa. I don't
Yeah, I mean, I
interchange.
feel it'd be a nightmare insurance-wise to get both covered because,
Exactly.
just because I remember even before my old job, we only took two medical plans, so that was already tough treating dry eyes in that way. But even then,
Right.
it's like as all the prior authorizations, and sometimes it can be tough, and there's like a lot of paperwork, and then it's hard to convince insurance, hey, pay for Xiidra and Restasis. So I can understand why that would be kind of difficult. But yeah, I've kind of had the same thing where Xiidra, I haven't used it that many times compared to Restasis, but it does look a little bit sooner, but I still feel like I got to like push it. Like, hey, it might take a while to kind of work. And then Cequa, I feel like 6 weeks I started to notice a little bit of improvement, but I just started using Cequa at the new practice, so I'm still kind of like learning with it.
Exactly. Yeah. 4 to 6. My general rule is 4 to 6 weeks for Restasis to start working. 2 to 4 weeks for Xiidra. But Restasis will get better and better and better as we approach a 6 month period. That's what I
Okay.
usually say, and that's what the research suggests as well. Um,
Okay.
but I would say let's maybe in terms of my patient base, percentage wise, I do see a lot of, like I said, rheumatological disease. So I do use it probably more than the average practice. And even then, I'm still using it maybe for 30% of my patients, 40% of my patients.
All right, Julian, we talked about dry eye, a lot of it immune based, but where does treating MGD play a role here? Given that we learn in school about 90% of dry eye is evaporative or mixed, do you hit a lot of them with doxycycline or warm compresses? Do you do supplementation, or what are your thoughts on MGD?
Yeah. MGD is a very tricky one. It's one of those diseases where everyone is so focused on it, and you should be. Like you said, almost 90% of all the dry eye that you're going to see is going to be related to meibomian gland dysfunction, right? Which causes what we call evaporative. And the reason, obviously, for anyone that isn't really in tune with the dry eye space is it's evaporative because the front layer is our oil layer. And if that is not being produced properly or in good quality, you're going to have the evaporation of the entire front surface of the eye, which is the tear film, right? So what I do for MGD is dependent on the severity. I always tell my patients taking care of the bacteria on the lids, which is our blepharitis, with the OcuSoft lid scrubs, or maybe we do a BlephX treatment. That is so important because that is one of the root causes why you have an inflammatory process focused at the lid there, right? On top
Hmm.
of that, clogging of the glands, right? This is a very, very tough one. There is no right answer to this. People do
Hmm.
warm compresses. I know I talked about warm compresses before and how they don't address the ocular inflammation. Yes, but with a super warm compress like an iLux or a LipiFlow or a tear care, a lot of the research shows that these things may work. It's not bona fide. They may work, and
Hmm.
that's why they're not covered by insurance. They may give the patient improvement. There is patients that do get improvement with this. And the idea is that if we heat it to a certain amount, we can actually liquefy those hardened meibomian glands or the content,
Hmm.
meibum within the meibomian gland and express them. That's why meibomian gland expression is so important. That's why these iLuxes, LipiFlows, and tear care are very important.
Hmm.
I don't want to say that these things are perfection because they're not. I want to wait for the future to see what we can do with MGD. It's a very
Hmm.
tricky space, right? There's one drug that's coming out. It's not named. It's by Azul Pharmacies right now. I'm following it like crazy. And I
Okay.
think it's in its second trial, third trial. And what it does is it is the first meibomian gland treatment, but it's a drug. And what it does is it actually targets the keratinocytes. When those meibomian glands get all crusted up and there's atrophy, what is actually happening is there's an hyperkeratinization of the gland, meaning that there's a buildup of this hard material in the gland. And what that does is it builds a network that prevents the gland from expressing itself, and then you get your atrophy and meibomian gland dysfunction. What this drug does, it is a anti or keratinolytic drug that'll break down the keratin and allow the glands to actually express themselves. This is going to be very, very important for our space. I don't know when it's going to be released, but meibomian gland dysfunction as a whole, if you're doing warm compresses for your patients or these things like iLux, doxycycline is fantastic. I'm a huge believer in doing a manual expression, BlephX, all these things that you're doing in your practices or wanting to do. I mean, they're great. They're great. To be able to voice how I treat my meibomian gland dysfunction treatments, it's tough. It's tough because everyone comes in with different severities, differing underlying issues, ocular rosacea. I'm usually working with a friend of mine who's a dermatologist right down the hall.
Okay.
Well, that was in the United States. Now we actually work with a derm clinic in Canada. They do our IPL for us, which is also a great treatment. So as eye doctors, my best recommendation when you're treating meibomian gland dysfunction, do as much as you can for the patient in terms of the research like IPL, BlephX, OcuSoft lid scrubs, getting those glands warmed up as much as you can, expressions. And also I would recommend search for the underlying cause. A lot of the problems could be related to ocular rosacea. And so, reaching out to a, local dermatologist or, a local rheumatologist to kind of co-manage is also a very, very important thing that I don't think a lot of doctors really, focus on. You just think the patient's in your chair, what do I do? Right?
Right.
Is so important for things like this.
Yeah, like if they don't have a dermatologist, like you need to have a dermatologist if it looks like they have rosacea. So,
100%.
and you mentioned doxycycline. What is your? Because this is another drug that I used to not prescribe at all. Because in school they were like, oh, UV photosensitivity, like.
Yeah.
And I found this like one of the most effective ones, like for preseptal or for like rosacea or for MGD. And so, in terms of dry eye, MGD in particular, or rosacea, what is like your dosage?
I usually use 100 milligrams once a day, and I do that for 30 days. Okay. I'm usually supplementing that with a steroid drop to open up the glands, which is great. I may do a 4-3-2-1 pred taper with the doxy so that you have the anti-inflammatory properties and sebaceous property of the doxy, but at the same time you have the topical aspect directly going onto the orifice of the meibomian gland to open it up. So that's the dual action that I use. Also with our, what I call my level 1 therapy, artificial tears, lid scrubs. If I think that it's, necessary, maybe a warm compress for that specific patient.
Okay.
Not for every patient, but that's usually what I'll do for my meibomian gland patients. Yeah, I really want to see new things come on the market. I'd love to see that one drug come out, the anti-keratinolytic one from pharmacies. Yeah, check it out. Search up Azul Pharmacies or Azul Pharmaceuticals. Forget the name of the actual. They have it's like a number right now.
Yeah.
I don't know if they have a name, but it's a good drug.
Yeah. And you did mention BlephX earlier. I saw on your Instagram you started doing this as well. What is it exactly so the audience is familiar with BlephX?
Yeah, so what BlephX is essentially, you compare it to brushing your teeth at home versus going to the dentist. BlephX is like coming to the dentist for us, right? The patient comes in with a ton of bleph, crusted, base of the lash, lots and lots of bleph, and they're still scrubbing. They're doing their OcuSoft lid scrubs, and you still don't see any improvement, and they don't see any improvement. They got the burning, they got the itching, they got the irritation, they got those collarettes, those pesky collarettes, right? Or even a Demodex infection. What this does, it's a spinning brush similar to the Alger brush, but it's got a foam tip on the top. I soak that in a hypochlorous acid solution, usually by the OcuSoft or, BlephX is another good one. And then I I put the foam on the patient's eye, and I literally, for about 3 minutes, just spin on the base of the lash with that foam tip. And what it does, it removes all the debris, and it really digs into the follicle to remove any type of Demodex that's there, stuck on makeup, stuck on, old sebaceous material, and it really cleans up the lid nicely. If anyone is interested in seeing the before and afters, I post a lot on my Instagram regarding BlephX, and it's, I would say, for anything related to blepharitis, it is one of the best tools that you can have in your office. If you're just starting out with dry eye, it's relatively inexpensive. It's a great option for your practice as a practice builder. It's very lucrative, and man, are the patients happy. The patients are very happy. And I believe you can train a technician to do it. At the beginning, I would start off just learning with yourself, but it's such a great tool. I would stress, if you want to get into dry eye and you only have 15 grand to spend on dry eye equipment, BlephX should be one of the first things that you purchase for your practice.
The first things. Okay.
Absolutely.
Awesome. Okay. So now this is the big question that I'm very excited to ask you, because I know you're a fan of this treatment. I see you post about this all the time, and it has a wow factor. Tell us a bit about dehydrated amniotic membranes, when they're indicated, if they're better than serum peers, what the results are. Give it away.
Beautiful. Yeah, this is what really kicked off my dry eye career. A lot of people were asking me because it's not readily used by a lot of doctors, and I think we should be using it more often, is the amniotic membranes. So for anyone that doesn't know what the amniotic membrane is, for anyone who's not a doctor watching this podcast, is they're essentially stem cells, or what I say to my patients, it's fertilizer for your eye, right? It's got that nerve growth factor in there to help build or regrow any dead, damaged nerves. Usually, this is indicated for my patients who have really bad filamentary keratitis. We're talking about front surface of the eye is very irritated. You throw some fluorescein stain on there and you're like, wow, it's lit up like a Christmas tree, right? It's not for the patients where you're seeing, okay, not much, the T-butt's a little bit, not that great, minimal staining, and they're complaining of severe dry eye problems. We're talking about the patient's Bell's palsy. We're talking about tumors in the brain that, cranial nerve 7 palsies, full palsies. We're talking about patients who have acoustic neuromas. Any nerve damage. Diabetes is a huge one. Glaucoma drops. Any of these things that will cause staining patterns and reduce nerve sensitivity, that's when I use it. When you're planning on doing amniotic membranes in your practice, one tool or one technique that I think people do not do enough, grab a cotton tip, pull it at the end, and touch the front surface of the eye. People do not do this enough. It doesn't cost any money. You see your patient, they have diabetes, they're on glaucoma drops, and they've, have history of problems with their eyes, dry eye. We know that diabetes, 50% of diabetic patients will get neuropathy in their feet. Why is it any different that they would not get it in their eye? Right? Your nerves are not working well as a diabetic. You're not healing properly. And if you're on any type of glaucoma medication, you are literally putting preservatives consistently onto your eye every single day, which cause neurotoxicity. Grab a cotton tip, touch the front surface of the eye, and grade the sensation. If a patient has a reduced sensation, they may have what we call neurotrophic keratitis. And this is when we absolutely indicate for amniotic membranes, because it is the only treatment that will actually regrow nerve bundles in the cornea, right? So one tool for anyone that is starting to learn about dry eye, touch the front surface of the eye. It's all about sensation, right? Neurotrophic keratitis is one of the most underdiagnosed dry eye problems because you'll see it as SPK. You'll see it as coalesced SPK. And it may be 1+, it may be a small amount. But what is the physiology? What is the pathophysiology behind it? It could be that the patient's underlying problems, systemic problems, or underlying ocular issues such as glaucoma, overuse of drops, or et cetera, is leading to what we look as, he has just SPK, but it's actually neurotrophic in nature. So I get a lot of patients that are referred to me for this particular reason. That's why I do so many. We do like 5 a day. Last year, I think I did about 750 amniotic membranes.
Oh my God.
But they are tremendous because they actually will heal the SPK. Like I said, it's like fertilizer to help regenerate the front surface of the eye, and it'll actually work to regenerate those nerve bundles, which at the end of the day, you have more nerves, you have a better connection to the lacrimal gland, which helps produce more quality tears and more quantity of tears.
Yeah. Man, yeah, no, that's great. Because I feel like in school, when you think about neurotrophic keratitis, like I used to think, oh, I still haven't seen that yet. I've seen a lot of disease, but I haven't seen neurotrophic keratitis. But you're thinking of like a neurotrophic ulcer, and you don't really see the ulcer. Like you said, it's just like coalesced SPK. And I have so many patients that they come in, they have lagophthalmos, so obviously their fear is going to be exposed, and it's just like 3+ SPK, and I'm in my head, I'm like, okay, I'm going to put you on a steroid, I'll see you back in 2 weeks, but like, there's no way you're going to be like fully recovered. So I feel like that would be a great addition to have. So I would assume you do steroid, plug, and then prepare them, kind of gear them up for the membrane after.
Not always. How I break my treatments down is level 1 through level 5. Level 4 to 5 is usually an amniotic membrane. But if a patient comes in with Bell's palsy, I'm usually doing it that same day. And then I focus on the other treatments for long term because I want to get them up and running. Gel at night, temporary tarsorrhaphy, taping the lid shut, and then having the amniotic membrane in there for, a week. You can do it for patients that have RCE that it's not healing. Over 80% of patients that have RCE will get it again in the same year. So why not use the amniotic membrane to regenerate those damaged areas, those, hemidesmosomes? It's very possible that can help replenish the strength in those areas. There's so many different things we can use it for. A big one, not even just dry eyes, I use it a lot for my herpetic patients, debriding the tissue, putting them on a Valtrex, and then throwing an amniotic membrane to regrow the area. It's very, very helpful stuff. And it wasn't until probably about 5 to 10 years ago when people started to realize, okay, we can use it for those. Why don't we just use it for dry eye? It's inflammatory. It's causing SPK at the front. Why can't we heal it? I think with filamentary keratitis and neurotrophic keratitis, it is one of the best treatments you can give your patients. They will look at you like you're a wizard, right? No one's ever mentioned this to me before. Why doesn't everyone do this? Why are they not offering this? Why don't they put this instead of Vuity on commercials? They're right.
Yeah.
They're right.
I mean, I think that's part of the wow factor with your account, with your Instagram account, because I remember you had graduated like 8 months ago at the time, after practicing, like doing some dry eye, and then I see you post like, here's like a terrible dry eye, like all this SPK, and then I just swipe right, and it's like 3 days later, it's like completely normal, and I'm like, what? And you're just like stem cells, man, like the amniotic membrane.
Anyone can do it. Anyone can do it. Like at the end of the day, I tell my other colleagues, I'm not a wizard. I'm not doing anything that is magical. You got to read. You gotta try and learn as much as you can every single day. You have to be prepared to fail. Failure is how you grow. If you want to get into this dry eye space and become a very, very successful at it, you have to be willing that 90% of your patients at the beginning will be failing, but you don't give up on them. You figure out therapies that will work. That's how I developed this whole dry eye, treatment plan. It's all through failure. I didn't show up one day and be like, okay, 2 weeks, show up this, that. No. I was telling them to come back, like you said, in like 6 months, and I'm like, holy crap, right? It's all about refinement.
Yeah, there's some educational try and error for sure, with experimenting different protocols per se.
Exactly.
You would agree that amniotic membranes are better than serum tears?
Yeah, amniotic membranes are bona fide in the research. Yep, there's very bona fide in the research. We're talking about sutureless membranes. They've been used for a lot longer. Serum tears, to be honest, I'm not a big fan of it. It doesn't mean that I'm right or wrong, but I once again have found so many meta-analysis reviews. There's not a lot of research on serum tears, but all the meta-analysis that I've read show that in symptoms, they improve the symptoms statistically, having that statistic significance, but the signs are not any different or significantly different from artificial tear therapy, which for me is I want to see improvements in both, right? You're not wrong for doing serum tears, you're not, but there's just not a single article that says serum tears work, it shows improvement, right? If you read through the articles and search it up, every single meta-analysis will say they may improve the front surface of the eye. Signs have not improved from significantly, but symptoms have. And so, yeah, it may be, something you add to your dry eye toolbox that may help. Anything that can help a patient is great. In the dry eye world, you're like, oh my God, I got this patient to be happy.
Yeah.
Let's roll with it, right? But speaking from a scientific side, I don't use it because there's not enough research.
Yeah.
In 5 to 10 years, I hope we figure out something that's great with serum tears because I think it's an amazing idea. But personally, I do not use it. I stick with my dehydrated amniotic membranes.
Yeah, and I would imagine that's why your membranes are covered by Medicare and medical insurances, but serum tears are not. And so while I think I have about 2 to 3 patients in my practice right now that are benefiting from serum tears because the doctor before them put them on serum tears and they love it, it's just it's difficult because you got to take them to a lab, get the blood drawn, do this whole thing, and then cost is a big like I've had multiple patients like say, oh, I tried it, but then like it was too expensive, I had to stop it. And so then you kind of have to think, okay, like what else can we do now that serum tears aren't working anymore for this patient? And so I see hopefully in the future it's more covered or it's made it's more readily available. The other thing I would say is in that I haven't done any membranes in new practice. We're in the process of getting membranes to our new practice, but in my old practice, because we only took 2 medical plans, it was at an OD prior practice. It was like about 40 years old. So I just couldn't do membranes. So for anybody who's listening to this and it's like, oh, I want to do membranes, but I don't have the ability to. One, see if you can find a way for your practice to order membranes or try it or and if you can't, maybe think of something like a different option. Like the one that I started using is Regenerize. I don't know if you're familiar with Regenerize. I had my aunt on it. It's not covered by insurance, but it's $80 a bottle, so it's definitely way more affordable. I would say it's kind of like serum tears, but it's like sterile. So you don't actually get blood drawn. And I found some benefit with it, but I use that if like nothing else works. And at the moment, I can't use a membrane, but as soon as I get the ability to, like that's coming.
Right, and for anyone that doesn't know about Regenerize, do some research on it. The reason why Regenerize, the idea is actually pretty awesome, is they're a stem cell drop. They have NGF, which is nerve growth factor in there, and what that does is it boosts up, like I said, fertilizer. It boosts up your ability to improve those nerve bundles, also by reducing inflammation on the front surface. Anything that reduces inflammation is great. I don't personally use Regenerize, and one thing that everyone will notice is that when you start listening to other dry eye specialists talk or people who love to do dry eye, they may do something completely different than what I'm doing. It doesn't mean that they're right or wrong. Everyone has their own menu. I don't do certain things, right? I don't do LipiFlow, right? I don't use LipiFlow. Other doctors do, right? So adding different things that work for your specific, practice modality and for your, patient, the type of patients that you have or where you're located, what is readily available, in creating something that works for your patient base. That's more important than just thinking, okay, I got to copy this person, do this to be a dry eye specialist. No, it's not like that. But for anyone that wants to get started with stem cells, you can always reach out to me on my Instagram. I love to teach. I tell Andreas this all the time, ever since school when we were tutoring. I love to teach, and I love to help any other doctor get started doing what I'm doing. What I'm doing is not a secret. I want to get it out to everyone. But it's as simple as learning how to apply the membrane, ordering the membrane from the company, and for those private pay patients, trying to make it as affordable as possible for them, especially the ones that really, really need it. So,
yeah, no, man, that's really helpful stuff. Really awesome. Again, happy to have you on here. to sum up this interview, I know it's been an hour. To sum up this interview, can you, obviously it's not easy to do this. If you were to summarize your main protocol for dry eye therapy, I guess you mentioned the level 1, 2, 3, 4, 5, or I guess what your mental flow chart is, like what's going through your head in your typical dry eye patient. I know everybody's not the same. It's just like if you had to summarize it in like just a few sentences, just to give like a little rough idea or kind of a almost like a sneak peek to what this podcast is about. I guess what would you say?
Yeah, so focus on inflammation, right? Don't just be giving out artificial tears to those patients that are struggling. You want to focus on inflammation. So get that patient that steroid. Don't be afraid to allow them to take it home. Don't be afraid to give them a steroid and say, hey, listen, if you don't see me in 6 months, use a pulse therapy 3 times a day for 3 days so that you can cut that flare up, right? Don't be afraid to give it to the patient, all right? So inflammation, seeing patients back on regular scheduled intervals, and build a cocktail. Build a beautiful 3-course menu of dry eye, okay? You want the artificial tears in there. You want the gel at night. You want the OxySoft lid scrubs. You want the steroids when they need it. If they're using plugs or stem cells or Restasis or BlephX, you want to build a house. Make that strong foundation so you can add on top of it. Don't just say, artificial tears, oh, that's not working, let's do a gel. Okay, gel, switch it to Soothe XP. Actually, no, let's switch it to Sustain Preservative Free. Oh, let's switch. Get out of that habit. Choose one good artificial tear, add on top of it. That's what I would say if you're looking to, build your dry eye practice and looking to be successful with the patients that are coming to you.
Mm-hmm. Brilliant, man. Well, that's it. Thank you so much. This is very enlightening. It's very helpful. I know literally tomorrow, well, not tomorrow because I don't work tomorrow, but on Tuesday, I'm going to go in and my dry therapy is already going to be better just from this podcast. And
I love it. And I encourage every single person to reach out to me if you have questions regarding to dry eye or you want to get started on dry eye. I'm here for your help. And don't be afraid to get started in something that you feel uncomfortable with. Exactly.
So, yeah, man, it was lovely having you. Maybe in the future I'll have you on again. But have a good, rest of your weekend, my man.
You too. Take care.